site to open. So in some vulnerable children, the skull fracture may get larger. How do we manage these? In a young child where we think that this may be a possibility, we repeat the skull x-rays a couple months down the, a couple weeks or a couple months down the road. Skull fractures that are lower, particularly in this area, I like to call the cricketer's wound, because it's a low blow in the temporal area, and this can result in injury to the middle meningeal artery and result in the epidural hematoma. These are the patients who get hit, dazed, get up, speak, okay, for a little while, and then deteriorate rapidly, seizures, and die in short order or a few days later. So linear skull fractures in and around the temporal area, we have to remember the middle meningeal artery, because this may be potentially fatal. Depressed skull fractures can be classified as either simple or closed or open, where obviously there's a laceration or open wound above the fracture. For most part, closed skull fractures will be managed non-operatively, particularly if they are above the sinuses, that is the sagittal sinus, torcular. But for open fractures, there usually is an indication to clean the wound up, so wound debridement. And if there is marked depression that is below, greater than a centimeter of depression, that wound should be elevated in. So a centimeter for adults, but think of it as a skull thickness. For children, if it's a skull thickness depressed, then you can have compression of the brain tissue below, and there's an increased risk of a dural tear, and those may need to be repaired. So elevation of the depressed skull fracture if it's greater than a centimeter or a skull thickness. All skull base fractures should be referred to neurosurgical care or facial-maxillary care, but in hospital care. The diagnosis is usually made, as with most medical conditions, a good history, examination, and investigations as appropriate. History of nasal bleeding or fluid dripping from the nose, or running nasal bleeding, or blood and fluid coming from the eardrum, or from the ear, sorry. In that situation, one has to examine, look for the so-called ring sign, where if the fluid drips with blood and so, and then you see a small splatter of blood at the center, and then it gets thinner as it goes away, or lighter as it goes away from that central dot. And that's a sign of CSF leak and should be managed under the neurosurgical care. Classical signs are the raccoon eyes for frontal or anterior cranial fossa fractures, battle sign for middle cranial fossa fractures. And here we have rhinorrhea when the ethmoid bone, the ethmoid bone immediately above the nasal area for smell is fractured. The so-called cribriform plate. Management is conservative, as said before, for the most part, but most CSF or skull-based lesions will settle on their own. But if the CSF leak persists longer than 2 weeks, then dural closure may be the best option. Will be the best option. Other mechanisms of injury to consider are for those for the brain, be it primary injury to the brain or secondary injury to the brain. Primary injury to the brain are lacerations, contusions, hematomas, and diffuse axonal injuries, which we will further explore, or secondary injuries that manifest as edema, impaired metabolism, altered cerebral blood flow, free radical formation, and excitotoxicity, increased risk of seizures or abnormal behavior. There is a new concept of cerebral cortex spread that is being discussed, and it interferes with long-term management of the patient, but that's a whole topic on it to itself. So, what is a concussion versus a contusion? A concussion is a temporary neuronal dysfunction after blunt head injury in which the CT scan of the brain is normal. The deficits resolve in a few minutes to a few hours, right? But in a concussion, the brain scan is normal. In a contusion or laceration, there is bruising to the brain. And we can see here where there's an increase or hyperdensity, which is blood being present in the brain with swelling around it. So a contusion, abnormal CT scan with blood. Concussion, normal CT scan. And diffuse axonal injury is damage to the axons. Remember, with neurons, there's a gray matter, which is where the cells are on the surface, and then there's the white matter along here, where the axons run. And diffuse axonal injury is damage to the axons. Cause of secondary brain injury may be extracranial, commonly in trauma, because we have associated chest injury, abdominal injury, or the fractures that may result in hypoxia from a pneumothorax or a hemothorax or a pneumohemothorax, or hypotension from loss of blood, or it can be due to intracranial pathologies such as epidural hematoma, subdural hematomas, brain edema, raised intracranial pressure, or later on infection. This is all to say that secondary brain injury is a result of hypoxia or lack of blood flow to the injured area or the at-risk area. And our duty is to prevent secondary injury by preventing hypoxia or hypotension. So the first rule in trauma is prevent secondary injury by addressing the factors that would cause hypoxia or hypotension. When we approach the injured patient, as with every patient, we want a history, examination, investigations as appropriate. For the head injured patient and trauma patients in general, we have the mantra, the ample history, where we take it for allergies, medications, past medical and surgical history, the last meal, and the event, that is before, during, and after the event. This will give us enough information in order to act confidently and clearly in helping the patient and preventing us from causing secondary injuries. We want to know the age, whether there's loss of consciousness, mobile seizures, anticoagulants per se, headaches, nausea, vomiting, but we'll get all of that as part of an ample history, as well as from the profile that is generated when the patient comes in through triage. So ample history, and we can go ahead and treat. Examination should flow along the ATLS guidelines, ABCs, airway breathing and circulations, and their necessary interventions as they flow, and the secondary survey, which we won't get much into for this meeting. But what I want everyone to take away from this is the Glasgow Coma Score. It's an old system developed by Teasdale and Jeanette back in 1974 in Glasgow. And anyone who has been there can tell there's a lot of trauma there. But it is how we speak to each other It is how we're able to communicate how bad the patient is or how good the patient is. And if we're not able to do this clearly and confidently, then we lose that step or that ability to communicate with our colleagues, particularly when we're transferring patients and for continued follow-up and management of the patient. So the glaucoma score, important for everyone to take away. And there are three components, call them EVM: eyes, verbal, and movement or motor. For eyes, scored out of 4, verbal component out of 5, motor component out of 6. The lowest grade one can get is 3, the highest one can get is 15. The lowest one can get is no eye opening, no verbal response, no motor response, akin to no signs of life. But an initial score of GCS3 does not mean that the patient is gone. It's just the initial score. For the eye component, we can think of nothing, pain, name, spontaneous. So no eye opening to pain, they get a score of 2. Eye opening to name or verbal command, they get a score of 3. And spontaneous eye opening, they get a score of 4. For verbal response, no verbal response, 1. Incomprehensible sound is exactly that. We do not understand anything. The groans, the moans, but 2. Inappropriate words are words that are said but that have nothing to do with the questions or the setting that that the patient is in. So if you're asked a certain questions and the response have nothing to do with the response, they are inappropriate. A confused patient is one who is not oriented in time, place, and person. So in order to get a full score of 5, one has to be oriented in time, place, and person. If one can speak, no matter how lucid the conversation is, if they're not oriented in time, place, and person, they get a score of 4. And then for the motor response, no motor response, 1. The extension to pain is scored as 2, which is called the decerebrate posture. I don't know if those online can see me, but it's ones where the hands are folded up towards the chest. And then the decerebrate are extended all the way back straight out beyond you. And then the decerebrate and the decorticate is one they're folded up towards the chest, or also called abnormal flexion. The score of 4 and 5 has always been a little bit tricky in the emergency room, but we can, and in the emergency setting in general, but we can use a simple technique in order to sort this out for ourselves. If one applies a painful stimulus to a cranial nerve 5, cranial nerve 9, back and forth, and the patient is able to bring their arm up above the level of the clavicle, that is considered localizing. If they're able to bring their arm up, but it does not go above the level of the clavicle, then it is called flexion response. So separate between 4 and 5, apply a painful stimulus to the cranial nerve, and those that bring it above the clavicle, 5, those that do not, 4. And then 6 is simple, they obey command. All right, so the glaucoma score, it is one of our pet peeves when persons from outside or doctors within the community can simply translate that information so we can tell exactly what is going on. And we believe that it can be garnered very quickly. You can get this information within less than a minute. So there's no point in giving a patient a GCS score that was obtained 6 hours ago or 4 hours ago, just before transfer. It only takes a minute to get. So when one is patient is being transferred, what we like is that immediate free transfer GCS. So we know what to expect. We know what to do. Or if the advice is to be changed, then we change it. Classification of head injuries are based on this GCS and are then split into mild, moderate, and severe. Mild, 14 and 15. Moderate, 9 to 13. When Teasdale and Jeanette came out initially with the GCS code, they had put 13 as mild. So if you want to see some text or so, they'll see 13 as mild. But when it was investigated, and in the era of the CT scan, we found that more than 50% of patients with a GCS of 13 had an abnormality on their CT scan. So it was moved from the mild head injury to the moderate head injury scale. And then a severe is 3 to 8. And now broken down from 3 to 4, 3 and 4 as critical, and then 5 to 8 severe. When the patient presents with a depressed GCS, always be cognizant that this may not be due to the head injury alone. This may be alcohol-induced on a Good Friday night. It may be a circulatory collapse from a heart attack. The patient may be hypothermic after having been out to sea, been out in the water or in the sea or in a pool. It might be a concussion where this is only temporary. Infections, meningitis, encephalitis can cause abnormal behavior and then result in a low GCS after a fall, etc. Be aware that something else could have occurred before. In fact, we have seen in Britain where people with a subarachnoid hemorrhage from a ruptured aneurysm are trying to drive themselves to the hospital, crash, and the patient is treated as a severe head injury rather than the subarachnoid hemorrhage that they truly are, and the diagnosis is made too late. So always be aware that there may be an underlying cause of coma. Focal signs may be seen in patients with cerebral abscesses, infarction, tumors, or intracranial hemorrhages. And investigations involve skull X in areas where a CT scan may not be available or readily available, or at night. But fortunately, as time goes on, we are getting more and more CTs in our country that make it available and make it the first line investigation in the head injured patient. The trauma series should also be done in the trauma for the trauma patient, where you do chest X-ray and X-ray of the cervical spine, plus or minus pelvis or long bones as necessary. The CT scan should be done in anyone who has a depressed GCS of 13 and below. That's easy. It is in our mildly injured patient we have a little bit of difficulty determining who should go to us for a scan. And the best study done so far and the best methodology is the Canadian CT head rules, which has been found to be 100% reliable in determining whether or not a patient will go on to develop a pathology or not. 100%, even better than the Nexus, which is only 98%. So for that reason, keeping it simple, here's the Canadian CT head rules. So needed for a CT in the adult emergency department for patients with minor head injuries, and it includes anybody with a minor head injury, with loss of consciousness, GCS 13 to 15, confusion or amnesia for the event. It is not as useful in patients below the age of 16 because in the study, even though they include more than 3,000 patients in the study, they did not include patients below the age of 16 in the study for the Canadian CT head rules. As such, one cannot apply it to them and believe that one is doing an appropriate job. Those patients carry a higher risk of requiring a scan. Anticoagulant therapy, be they having a previous bleeding disorder that is congenital, or they're on medications such as warfarin, aspirin, etc., those patients are at higher risk and require a CT scan, and of course, anyone who had a seizure. So the high risk factors that they found in the Canadian CT head rules were those who had a depressed GCS of greater than 2 hours, suspected open skull fracture, a base of skull fracture, vomiting more than twice, that is 3 or more, are age greater than 65. And those at medium risk were amnesia post-event greater than 30 minutes, or a dangerous mechanism, such as a fall from a height of more than 3 feet, or a pedestrian struck by a vehicle, or those that were ejected from the vehicle. So even those patients, when they present at a GCS, that is normal, one should err on the side of caution and scan them. Other basic things that might be relevant have been covered by the Canadian CT head rules. Okay. Brain injury can be diffuse or focal, and diffuse concussion where there is no anatomical injury to the brain discernible on CT scan, or diffuse axonal injury, and of course focal lesions like contusions, lacerations, hematomas, either extra axial or intraparenchymal bleeds. Extra-axial bleeds are those that occur between the skull and the surface of the brain, be they epidural or subdural, and then intraparenchymal bleeds. Let's look at concussion. Again, there is no structural lesion, and the returns within minutes of the impact. There may be brief confusion, disorientation, headache, dizziness, or amnesia. Again, the CT scan is normal. But do not be fooled, because concussions can be significant. A concussion in our day-to-day patient may not have much impact on their life, but imagine if Messi came through the door, or one of the cricketers, or a sporting star, another sporting star. A concussion in their field is significant. So why should we then deem all of our patients with a concussion as not important? We have to be able to at least assess and see which patient with a concussion may be a little bit more at risk than say, oh, you will be fine and you'll be back to work in a day or two. So there's a concussion questionnaire that can be sourced online, but the important things are headaches, dizziness, and nausea and vomiting. If these are particularly severe in that first few days, these patients are at high risk of having long-term symptoms and may need a little bit more rest and a little bit of medication, be it anti-nausea medication, be it pain medication, be it a little sick leave, time off. Those patients require a little bit more time. And remember, we think of concussion as occurring as only being significant after multiple events, but a concussion that can result in CTE or chronic traumatic encephalopathy can occur from a single event, such as we have IEDs in our environment, in explosions or bombs, but a significant head injury can cause long-term side effects or injury to the brain, similar to an IED. So now, because the patient is GCS 15 and has a concussion with a normal CT brain, if the mechanism of were particularly significant, be a little kinder. We're going to look at the other aspects of head injury, such as epidural hematomas, which has an epidural collect between the dura mater and the skull, right? The subdural, which collects below the dura mater. Subarachnoid, which the traumatic subarachnoid hemorrhage is the commonest subarachnoid hemorrhage encountered. But spontaneous subarachnoid hemorrhage is usually of a vascular phenomenon, 85% of them being aneurysmal. But overall, traumatic subarachnoid hemorrhages are the commonest subarachnoid hemorrhages encountered, and may have some effects on the patient, including seizures, etc. and then intraparenchymal bleeds. And we have various grading systems for that, but I don't think we need to delve that deep to this presentation. So hematomas, subarachnoids, subdurals, epidurals, intraparenchymals. All right. How do we manage these more severe or this part of this group of patients? Again, ABCs: stabilize airway, breathing, circulation. IV access, maintain them normovolemic. Do not give glucose solutions. Normal saline is an infusion of choice, right? And an endotracheal tube is necessary if the GCS is 8 or less. Head elevated to 30 degrees, treat for coexisting injuries. Chest tube where needed, a cervical collar for the fractures. In fact, as soon as the airway is being assessed, a cervical collar should be going on because of the high incidence of concomitant cervical spine injury. Dilantin, loading them with an anti-seizure medication. Dilantin and carbamazepine have been studied. They're falling out of favor in first-world settings, and intravenous Keppra is the drug of choice now in trauma. Unfortunately, we don't have that as widespread use here. So we're still using Dilantin as our drug of choice. We're loading dose 18 to 20 milligrams per kilogram, and then they're maintained at 100 milligrams per kilogram for it all. So on average, an adult will load between 900 and 1.2 grams of Dilantin. And you do this over approximately 20 minutes, 30 minutes, no faster than 50 milligrams per minute. If it goes faster than that, then you can have the abnormal side effects from acute Dilantin toxicity. So aim for more than 20 minutes, or approximately 30 minutes when one is loading, and be aware of the risk of hypotension with the use of Dilantin for patients being loaded. For those patients who do not go on to require surgical intervention but are observed, the so-called neuroobservation, these are the things that are part of the neuroobservation that are done either Q15 minutely, Q half hourly, or Q1 hourly, up to Q2 hourly in the acute setting based on the need of the patient. So it's the GCS, the vitals, blood pressure, heart rate, respiratory rate, and temperature, oxygen saturation, pupillary size and reactivity, and limb movement. So it can be quite involved. And unfortunately, after many years of work in many hospitals, both here and abroad, it's very difficult to get nursing staff or staffing to be able to give us this kind of monitoring on any single patient through the night when they come in. So we have charts that are given that should be used in order to help to pick up early deterioration in these patients, so that if there's any deterioration, and deterioration can occur even from the emergency room or in the not the consultation, in the reception area. So we should be able to pick these up right away and act upon them, right? So there are charts in order to monitor these patients, if not necessarily in the reception area, but definitely in the emergency room, definitely on the wards, to make sure that we can detect any deterioration in our patients and step up the grade of management. In all these conditions, there is the element of raised intracranial pressure. And the intracranial space has three main components: brain tissue, accounting for 80% of the pressure, blood and CSF, 10% each. Normal pressure is between 4 and 15 millimeters of mercury, and anything greater than 20 is deemed abnormal, or at that point that we treat. So there's a wiggle room between 15 and 20 where we won't intervene. And this is in the trauma setting. This is not for the idiopathic intracranial hypertension. That's a different group altogether. This is for normal pressure before the head injured patient. We look at those three components and then uh, remember this term or remember the name, the Monroe-Kelly doctrine, which tells us about the cranial vault being a rigid structure, and therefore that alterations in any of these components can result in raised pressure, be it swollen brain, increased blood, or increased CSF. When any one component is increased, the others have to compensate or offset a little bit in order to minimize the pressure or to compensate for the pressure. But this can quickly be overwhelmed. Cerebral perfusion pressure is that amount of blood pressure reaching the intracranial space. So there's the pressure that is generated by the heart called mean arterial pressure, which looking at the systolic and diastolic pressure. So that's the head pressure that is generated by the heart. And then there's the intracranial pressure, that's the resistance inside the brain. And when you subtract the resistance from that head pressure, you will know how much pressure is actually getting into the head. So CPP is equal to mean arterial pressure minus the intracranial pressure. We know that a patient are showing signs of raised intracranial pressure by diminished consciousness level, headaches, vomiting, seizures, and very rarely the classic Cushing's triad. Cushing's triad is bradycardia, or slowing of the heart, hypertension, raising of that blood pressure in order to overcome the diminished CPP, and abnormal respiration. Pupillary changes can occur where there may be dilatation of one or more pupil and papilla edema or swelling behind the eye. In an acute setting, acute trauma setting or acute deterioration of patient, papilla edema will be hard to detect, and I wouldn't even advise trying to look for it. When patients start to deteriorate, I want to see no one whipping out an ophthalmoscope to try to look for papilla edema. It's time to act, and we will go through that. Brain herniation that can occur in raised intracranial pressure or swelling of the brain includes subfalcine herniation, that is movement below the falx, the uncal herniation at the level of the midbrain, or consular herniation, or even a central herniation where the whole midbrain and brainstem moves down through the so through the cerebellar diaphragm. Thank you. Treating head injuries. Now, of course, there are members of the audience who will encounter this outside of the clinical setting. And if that occurs, conduct a quick primary survey, airway, breathing, circulation, call an ambulance, call for help. If the patient is conscious, put the patient in the so-called recovery position, rest them comfortably, reassure them that help is on the way, and monitor their vital signs. If they're unconscious and not breathing, commence CPR. I think in some first world countries, all medical practitioners are required to administer CPR in the emergency setting, no matter what. And if you don't do so, you're at risk of losing your license. We don't have that rule here, but I think it's good that we make sure we are at least prepared. So if we have a little face mask that can help us in an emergency situation, it might be a nice thing carrying in your vehicle or in a little pocket if you or in a little bag if one carries those things around. In the hospital or clinical setting, then for GCS 8 or less, an airway is needed. Goodell or decrease swelling. Mannitol is administered in the acute setting at 1 gram per kilogram, and then may require quarter gram per kilogram Q6 hourly for the remaining 48 hours. Can't be used for very long or more than 48 hours because then it deposits in the brain and forms its own osmotic agents that will pull water back into the brain and cause further swelling. Other agents have been used, thus including hypertonic saline, in order to negate that effect from mannitol. And of course, rapid neurosurgical intervention. Ventriculostomy or craniotomy or decompression may be necessary for these raised intracranial pressures. So let's get more specific. Skull fractures, again, things to ask for: depression of the skull, altered level of response, distortion of the face, blood in the eye, clear fluid drainage from the eyes, from the ears or the nose, bruising around the eyes, bruising around the ears. And if there's a skull fracture, then manage according to linear or depressed, as we discussed before. Epidural hematomas, usually from a torn middle meningeal artery. Most epidurals are from from a venous source than an arterial source, of 40% arterial, 6% venous. And as a break in the skull or so, and a slow build-up of blood. And that can be slow, can allow for the GCS not to fall. The patient may even have a large epidural hematoma greater than 2 centimeters in depth, inch in depth, greater than that 30 cc when they present, but be very alert. Those patients still need to be referred and managed neurosurgically. It's an uncommon presentation, but it is serious. Like I say, it's a cricketer's wound, it's a sporting wound, and it can be fatal. Highest among adolescents and young adults, and one usually sees a skull fracture in about 80 to 90% of patients. There is the classic lucid interval, which may occur in epidural hematoma, where a third of patients are said to have lost consciousness, gotten up, walking around, be fine, and then suddenly lose consciousness and seizures, etc. die. The lucid interval is rare, so that shouldn't be our diagnostic mantra to make the diagnosis of an epidural. One must have a high clinical acumen and suspicion if there is blunt head injury, particularly to the temporal area in young adults, and be willing to investigate and manage them. Epidural hematomas due to venous bleeding, again, is a slow neurological decline, but usually present as their headaches and confusion over a few hours to days, and should be investigated after that blunt trauma. Posterior epidural hematomas are particularly difficult set of patients because they can go to a GCS3 very quickly and may be given upon, but rapid evacuation of epidural hematoma from the posterior fossa may save those patients. So they present very early with very low GCS, but if they can be acted upon very quickly, usually even less than the so-called 4-hour window or the golden hour that we have for other epidurals, then they can be salvageable. Diagnosis, of course, is a CT scan, and they have the classic lens shape from being trapped by the dura against the skull, the biconcave lens shape. Management is craniotomy and removal of that thick current jelly hematoma. It is so thick that it cannot be drained by a subdural, by a burr hole. So it has to be craniotomy. One has to remove the covering over the hematoma, evacuate that clot, wash it away, slowly peel it away. And then usually the brain and the dura are pushed away from the skull. So if one puts back the skull immediately after, just as after the decompression is done, one runs risk of having the hematoma recollect. So every young neurosurgeon starting the trade knows that they do what we call tack-up sutures. We'll make a hole in the skull and around the edges and pull that dura up to meet the skull to obliterate that space in order to prevent them from recurring. They have a fairly high mortality rate when mixed of 10%, but these are patients that you can operate on within that going or within a period of 4 hours, and within a day they look like they're ready to go home as if nothing ever happened to them. The subdural hematoma is a result of injury to a bridging vein. Those are veins that are running between the cortical surface of the brain and the sinuses, and these can be easily injured in the older population because there's a larger space and these vessels are running in that subdural space and easily torn, or damage in severe head injuries for the younger population. It takes a lot more energy to be transferred to the skull and brain to cause a subdural hematoma in the young than an epidural hematoma. So the mortality rate and the post and the poor recovery and all the other complications of a head injury are higher in this category of patient. I think all of them will end up sending to the neuropsychologist because they're always very bad. Again, the clinical manifestation is based on the raised intracranial pressure, depressed GCS, vomiting, and then poor responsiveness. They are not biconcave, but they're now crescent shaped because they spread over the surface of the brain. They present a coma in 56% of patients. Some of them may be lucid in 12 to 30%. And the posterior subdural hematoma similarly can be salvaged, but again, these are high injured patients and usually end up with an even worse mortality score or risk. The clot is bright when it is acute, and as it gets older and the blood product breaks down, it becomes darker and so-called almost engine oil colored. And as it breaks down, it goes from being white on the CT scan to almost the same density as the brain, and then even darker where it is, where it becomes black compared to the younger elements. For both the subacute and which might be isodents, and this usually occur between anywhere 10 to 21 days after the injury, or 7 to 21 days after the injury, and then chronic after that 21-day injury. Both of these can usually be managed by a burr hole evacuation. We'll go to the thickest point, and if there's a significant collection inside there, you might choose to do 1 burr hole or 2 burr holes, depending on choice. If there are particular septations inside there, that means that the multiple pockets of subdurals inside the subdural space, then we might choose to do more than 1 hole. But a subdural in the subacute or in the chronic state can usually be managed by a burr hole. The acute setting, acute subdural, requires a craniotomy. In fact, most of them will require a decompressive craniectomy, because of the amount of injury to the brain to allow the brain to swell and relax. And these are severe head injured patients that end up in our ICU setting. Again, lots of blood. It's thick. It doesn't just flow out. One has to remove it, peel it away slowly and gently, separate it from the brain, find the bleeding points in terms of the torn vessels, stop those, and treat the brain gently in order to prevent any further damage. In some cases, the brain is so swollen and damaged that the brain actually ruptures or bursts in front of you while you're trying to operate. So in that situation, you need to recreate the covering over the brain in order to give that brain room to expand. Chronic subdurals, like I said, can be drained by burr holes. So this can be done in the operative setting, as in inside the operating theater, or even be done on the ward with a small trephine. And of note, our next group of patient is the diffuse axonal injury patient, which may be mild, moderate, or severe. Severe has a 40% risk of mortality, and the mild only a 10% risk of mortality. Thank you all very much. We'll skip over the complications, I guess I've mentioned as we've gone along. Again, severe head injuries, they don't just bounce back to being normal. The concussive patients don't just bounce back to being normal. Be aware there are frequently changes in the home, how they behave, and that is why, as a big part of our talk today, we're going to discuss the neuropsychological effects of head injury and how we should be caring for them. Thank you. I am going to be introducing Dr. Georgia Rose, Senior Clinical Senior Clinical Psychologist, and we will get to her presentation in about 15 minutes so that everyone can take a break, grab a drink, and then then we start. Thank you. You're gonna put
Good evening, ladies and gentlemen. Thank you so very much for that introduction, Dr. Pencil. Once again, my name is Georgia Rose, and I will be speaking to you this evening on the role of a neuropsychological evaluation in the management of the patient with a head injury. It's not going to be very long, so that's a good thing. We're going to be short and quick to the point. My aim this evening is to increase your awareness of the value of a neuropsychological evaluation or assessment, what it does, and how it can be of benefit to the client and your goals for management and treatment. So, what is a neuropsychological evaluation or assessment? It is a non-imaging assessment of the active function of the brain in relation to its premorbid history and current state of compromise. So it seems not to understand the changes of the brain's architecture that may occur as a result of the trauma, but the modifications to the input and output that occur as a result of such injuries. So what we want to have an appreciation of is, before we had these sophisticated imaging studies available to us, clinicians really relied on neuropsychologists to help them understand the locale of the injury and how the patient's day-to-day life was being impacted by such injury. And given that information, how could we then intervene in a meaningful way? And we're going to talk about how this has changed a little bit over time and where we are presently as it relates to the neuropsychological evaluation and the neurological intervention. So while brain imaging studies might identify the locale of the injury, the integrity of the structure, and the dysfunction of the interconnected regions, it is the narrative of the neuropsychological evaluation that provides depth to our appreciation of the functional disturbance of neurological structures. I remember as a graduate student being so fascinated by neuropsychological evaluations. And, you know, when you enter into clinical psychology, there are so many different fields and avenues that you can step into. And I have now gotten to a place where I really love working with children and adolescents. But early me in graduate school thought I would have become a neuropsychologist because it was so intriguing to see how people responded as a result of different brain injuries or brain infections. And you got really caught up when you would do these assessments and see how the client would progress through these assessments. So it really is a very diverse and beautiful field. We don't have it practiced very heavily in Jamaica for lots of reasons, and I'll talk about that as we go forth a little bit more. So the advent of neuropsychology sought to provide clinical insight in the absence of what we now appreciate and know as modern imaging studies. The neuropsychological evaluation allowed providers to gain an understanding into the neurological impairment, because more and more in medicine and healthcare, we recognize while there might be certain general truths as it relates to disease and disease progression and illness and trauma, we're all individuals. So one individual or one patient with a frontotemporal injury may not necessarily look the same as another patient with a frontotemporal injury. And the neuropsychological evaluation seeks to say to you, the client may have this injury, but these are the areas of functional impairment. Can the client do this? Can the patient do this? Therefore, what are the recommendations that you're going to make? Is it speech therapy? Is it physical therapy? Is it occupational therapy? What is suited in the best interest of the patient that is before you? The primary purposes for a neuropsych evaluation are: one, to detect neurological dysfunction, the differential diagnosis; two, to conceptualize cognitive strengths and impairments. We talk about conducting a functional assessment. At this moment in time, what is the functional capabilities? And given our understanding and our awareness of the illness and of the injury, what do we expect in 3 months, 6 months, 1 year? It provides prognostic predictors. Do we expect the patient to improve given the premorbid history and the comprehensive assessment before us, or do we expect that the patient might decline or remain at the baseline that is before us? It also helps us to inform patient support, inform management, and provide practical realistic, and patient-guided support. As imaging capabilities become increasingly sophisticated, the neuropsych evaluation has also had to evolve from its original role. So as I said in my earlier speech, that initially the neuropsych evaluation's role was to identify where the injury was, because we did not have these imaging studies. We now have these imaging studies, and there are lots of advancement that keep occurring. There are new studies that are coming out, new capabilities of every study, more high definition machines that exist out there. So does the neuropsych evaluation still have a place? Is it still valuable? So it has had to evolve, and it has now gotten to the place where it is also becoming more sophisticated based on the measures that inform a part of the battery of a neuropsych evaluation. And it now is able to provide in-depth characterizations of the patterns arising from the disruptions in brain behavior relationships. So while it might seem mousy to the Goliath of neurophysics and engineering, advancement in neuropsychological evaluations have generated cognitive assessment tools that are, one, sensitive to brain behavior relationships of interest, developed alongside other brain measurement tools, and accessible and feasible across diverse settings. And if you know a little bit about neuropsych, it was developed by a gentleman by the name of Halstead and his student Wrighton. Now, Wrighton got, I want to say, acknowledgement rights because he helped Halstead to validate the battery components. He tested over 800 individuals without having even known what their clinical diagnosis was, and his assessments were correct. And this was based on the reliable information that was provided by the items or the measures that construed the battery. Over the years, all of these measures have been updated. They've become more sophisticated at identifying brain behavior changes. So it has made the neuropsych evaluation that more credible and valuable in what it brings to the table in the field of neurology. Walter et al. Proposes that neuropsych evaluations provide a meaningful option for non-invasive and affordable options to evaluate brain disease progression and impairment. This is a North American study, and I found it a very interesting position because I don't necessarily know if this affords in Jamaica, and I will say why to you. A neuropsych evaluation is very costly. The complete compendium of a battery can run anywhere up to 3,000 to 5,000 US dollars. That's a lot of money because the battery is made up of a number of standardized measures, which are all quite very costly. The WAIS alone, which is the Wechsler Adult Intelligence Scale, will run you up to 2,000, a little bit over 2,000 US for the kit. And the kit only comes with so many response booklets, and there are many other tests. There are about 7 other tests involved in the battery. And the prices have increased. Now, when a clinician brings that into the island and pays their custom fees and all those other duties that they may have to pay, and sits down with a client for 3 to 4 hours or 5 hours, and then takes that information and then spends another 8 hours scoring the information, and then spends another period of time researching how the findings relate to what we expect from the injury or the lesion, you're going to get billed for that. And that's going to run you anywhere from $160,000 upwards, depending on the purposes of the assessment and the ensuing report. Now, that's a lot of money in comparison to what it costs for an MRI or a CT, right? And while insurance companies may cover a portion of an MRI and CT, they're not going to cover that much for a neuropsych evaluation. Now, in Northern America, the neuropsych evaluation at 3,000, 4,000 US might be significantly less than all the other imaging studies combined, but the converse does not apply here in Jamaica. So I don't necessarily believe that we benefit from the affordable option as a pro for a neuropsych evaluation. It makes it very limited for the average person to afford. And I don't know how much of within our setting and our systems do our practitioners take on all of that responsibility. But it is a very beautiful piece of clinical art. I call it clinical art because if you are truly interested in the capacity of your patients and how they may progress, some of our clinicians may see their role as only to diagnose. This is what your injury is. This is what our history and our studies and my clinical expertise says or tells me, and that's it. We don't do any more. We're finished with the patient and we might put them through the door. Maybe we prescribe some medication to delay or to subdue any further deterioration, and that's about it. But if we go into holistic management and care of the patient, and I think Dr. Penslow was speaking about the changes that the relatives at home might be noting, and the relatives want to have an appreciation of how long are we going to be in for this? Is this normal behavior? Do we need to get external help? What are the recommendations? Then the neuropsych evaluation does provide a wealth of support, and it increases our capacity and our capability to provide informed support and options for family members. Given the client's premorbid history, this was a professor of math. We expect that they should be able to do basic computation, that their abstract reasoning, that their judgment should be at a particular level. So even though they have this injury, maybe 9,000 other patients with a similar injury do not demonstrate or present with these deficits, but this professor is not doing so well. You would find that the neuropsych evaluation might say that this is a transient impairment, or this is something more prolonged for this individual. So it is a very beautiful piece of art, clinical art, but it may not necessarily be accessible for everyone. Unfortunately, the constraints of our public health system make a neuropsych assessment a very fancy thing. Yes. We don't have the luxury of time to be spending so many hours with one patient. And sometimes persons don't understand that. Very often we're asked about psychological assessments or psychodiagnostics in a very general and broad scale term. And what we have to be reminded of is our constraints, or medical constraints, or social or socioeconomic constraints. Because if you are going to devote 12 to 15 hours on one patient, you're going to have to be able to bill for that and go beyond billing for it. You have to rationalize the value of it, because when general medicine can see 100 patients when you're still working on one, no one is going to necessarily be in support of that. And the appreciation that there are restrictions and limitations to these batteries, and you have to update them and replenish them, and we don't do a very good job of that. So we might buy to Cornwall, and I'll talk a little bit more about that. Cornwall does have a neuropsych battery, or we had it before we relocated due to the closure of the space. I can't really tell you where it is, unfortunately. That is a challenge of, relocation. It's packed away somewhere, but unfortunately, we don't necessarily have the resources or the financial capabilities to keep replenishing it. And if you take one of two clinicians and put them in a room and say, you're going to do neuropsych assessments, then the other matters that come before us do not get attended to. So we see the challenges here. So the Halstead Wright neuropsychological test battery is the gold standard of neuropsychological assessment. I spoke a little bit about it. It was developed by this wonderful man and his students. It's used to perform or to inform a comprehensive assessment and profile of the patient. It's not really used right now to diagnose. It doesn't say that this is the injury. It really comes from a functional assessment. This is what is impaired. So it looks at cognitive domains. This is what we expect. We're talking about our working memory, or reasoning, or long-term memory, or short-term memory, things like that. And it looks at to see where the patient is, how they're functional in these spaces, what the impairment looks like. Is this impairment normal? Is it normal with age? People get very surprised when I tell them that memory loss is not a part of aging. You're supposed to be able to remember. A lot of people think that it is normal and natural for you to lose your memory. So it's quite an interesting thing to see patients move through the scales or the tests and how they perform on them as a result of that. The Halstead-Ricson test evaluates a wide range of nervous system and brain functions, and these include your visual, your auditory, your tactile, your verbal, your spatial, your sequential perception, the ability to analyze information, form mental concepts, make judgments, reasoning, decision-making, motor output, attention, and concentration. And these are all integral parts of a person's ability to function and move through their daily demands and be very functional members of their family and their community. As patient assessment, care, and management evolves, it becomes increasingly critical to explore the dynamic opportunity come to the hospital and do that, but we couldn't employ somebody just to do that because it's really not a standard part of our offerings. Once again, it becomes that very fluffy part of our service because of the time cost and the financial burden that is associated with it. But maybe we need to get to a place where not because we are a third world country or a developing country, however you want to look at it, and not because it is public health care. Public health care maybe needs to be redefined where it is the best health care. So when you go to the public service, you are getting the best, and that is probably a very utopic approach or view of what our healthcare system might look like. But I believe that it should be a very utopic type of ideology that we start to look at in a very practical and possible manner. So across all specialties, we now understand the extensive benefits of a multidisciplinary approach when we look at the patient. No longer can we see the patient in one space, where when neurology looks at the patient, it's only neurology. No one else provides insight or recommendations or suggestions, because if we really want to preserve quality of life and give individuals the best possible fighting chance, because we do understand that the brain has periods of sensitivity, and if you intervene during these periods of sensitivity, then the prognosis is much better than if those windows go through the door. So if we know, it's like when we have clients who might be on the spectrum or have other developmental delays, and we say to parents, the brain is quite malleable at this time. If you introduce speech therapy or occupational therapy, you might be amazed to see how you can modify the brain architecture, even though the child might be predisposed to this delay. It is the same thing. When individuals have had any injury of any kind, if you have meaningful intervention in a timely manner, then we know the studies tell us that the prognostic indicators look that much more favorable. And that is really the role of the neuropsych evaluation. How do we support the patient? How do we support the family? How do we strengthen what the medical clinical team is bringing to the table? It is best understood as an additional measure of exploration, and it should no longer be seen as a standalone for the management and support of our patient and brain injury. So decades ago, it stood by itself. The neuropsychologist was working alone. We now know, and we now have an appreciation that the neuropsych evaluation, in collaboration with everyone else who is a part of the team, adds a wealth of benefit to the management of the patient who might have experienced a brain injury. And I thank you. That's it. Are there any questions?
No.
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 Well, we'd like to explore any questions either in person or online at this time.
It depends. Right. So it really depends on the level of functionality of the patient at that point in time. A standard assessment runs anywhere from 3 to 5 hours. You may not do all of it in one day because that may not be ideal for the client. But when you think of the burden of responsibility as it relates to the consultation, the actual assessment itself, the scoring of the responses, and the generation of the report, looking at about 10 to 15 hours. So it's a lot of time. So when a psychologist charges you, they really charge you for the time. That's what you're being billed for. That is why it costs so much. Yeah. I see Doc shaking his head.
I have to say that it is frustrating to make a clinical diagnosis, see the patient, see the deficits, particularly the head injured patients that we have had over the years, and know that there is a next step where they need to be neuropsychologically evaluated, find where those deficits are in the short term, working, all those things that, and then I know as part of not only finding those things, you tell return is temporary, return is permanent, and how to help, but coming into the hospital, it is the end of the all of making the diagnosis of a head injury, getting a surgical treatment, and being put through the door, and then only for a follow-up. We know that there is a next step. The few patients who may be able to get these are particularly government workers, particularly police officers or something, who need to have these evaluations done. Because how can you take a severely head injured police officer after and then, okay, he's good.
Put him back on front line duty.
And give him a gun in his hand. He should be fine. We have to be able to best manage these patients and then make sure that they are, capable of returning to work. Hopefully, in the future, we can see where more patients get to neuropsychological evaluation. Any framework for this in either the public or the private setting?
Not that I am aware of. I know we had one person who was really committed to neuropsych evaluations or neuropsychological practice. That was Dr. Tammy Haynes, but she left the island a few years ago because the reality is that it's not very financially feasible. It costs a lot of money to study. It's a continuous upgrading of self. It takes a lot of time, but it's very hard to bill for something like that. So then it's not practical for you from a financial point of view because you have to be able to recoup. Well, someone can appreciate a neurosurgeon charging hundreds of thousands of dollars for surgery, and we get that. Someone might struggle to say, I'm going to pay you $160,000 to have me trace a piece of paper or tap a thing or put some pegs in a spot. You think about the different tests or sort some cards. You think about the Wisconsin card sorting test. You're just sorting cards in a particular order, or you're drawing a reosterith 3 times. So that's all I'm going to take my $160,000 doc. You're wicked. You're a thief. Versus somebody is more willing to, the doctor went into surgery. Doesn't matter if the doctor took 1 or 2 hours in the surgery and he's finished, they're going to pay the 600, the 1 million, whatever it costs. So when you think about somebody, one, being intrigued into going to study that, they're not going to, especially if you're going to remain on the island and practice here. And 2, if you are fascinated by it and you want to invest in yourself and you are going to go away and study that, because that is not taught here. When I was taught neuropsych evaluations, our instructor came from the US. It was an intensive course where the person came down and taught us and assessed us. So that person was not existing here. I know Dr. Edwards, who used to work with the JDF. Yes, Dr. Edwards, before his retirement, would do a lot of the neuropsych evaluations along with Dr. Tammy Hayes. I don't know if Dr. Edwards still practices that anymore. So if you think about it from a financial standpoint, it doesn't work out for the clinician, unfortunately. So until we get to a space where we're investing it and we're educating our clinicians on value and our society gets an understanding and appreciation, then we are going to see some struggles. I find clients who have a litigation pending and who believe that the neuropsych is going to increase their chances of getting more money will pay for it. Yes, because you're going to do a CT and it's going to say that there is, there's some impairment, there's some damage right here, but that's it. That's all the MRI is going to say. They're then going to rely on a neuropsych evaluation to say that we expect to see, long-term memory loss, that is going to impair their capacity as a professor or a teacher or a police officer. The burden of disease looks like this. It's going to impact their economic earnings. So they run to you for it because they believe that what they're going to get is way more than the 160 or 200 that you're going to be charging them. But how many of those cases do we really have? Because we're not a very litigious society. So while a lot of us might be fascinated in it and may have some basic training in it, the buck stops there. And that is the reality of it.
I think as a society as a whole, we have to stop just surgery, which puts years into our life. We have to start to think of ourselves as people.
Yes,
and
quality of
put
life.
quality of life into our years. And we have to start treating each other and treating ourselves better and start thinking about what would be actually best for us rather than just what our pocket can do in the moment. Because if we think pocket only, it ends up short-sighted and ends up hurting ourselves or family. So we have to think as a society to move beyond just our pecuniary assessment, but how we're going to overall build and improve our entire society and look at these things that are available and necessary in order to move to the next step for healthcare system.
Thank you so much. So I have a quick question. So is it standard? I know you worked here and abroad. Is it standard for the neuropsychiatric evaluation to be a part of the entire assessment overall?
For all our severe head injuries, yes. For all of our concussions, yes. It's how we're going to be able to reintegrate those patients back into society.
Right.
Apart from the, I tell people all the time that Jamaica is a land of sharks. If you cannot swim, you will die in this country. Abroad, you have workman's comp, you have all these support systems that are put in place for that society. I think as a nation, we need to think better of ourselves and do better for ourselves. And yes, and neuropsychological evaluation is an important part of the evaluation of the head injury patient.
Yeah.
There's a question.
So if there are no more questions, we'd like to thank everyone who joined us in person and online for this presentation on head injuries and neuropsychological impact and the necessity of managing the complete patient, not just a picture and a scan. And remember, the brain is for function, not just for structure. I'm being reminded that please remember to register and pay at the online at the engine.info conferences for CMEs, which will be available by the end of the week. Thank you all for joining us. Thanks, Dr. Georgia Rose again. Thank you.
You know it's Miss Georgia Rose, right? I thought you realized. I keep correcting people, but that's fine. Thank you, Dr. Prince. So wonderful. Thank you.